Alrighty, well, welcome everyone to Sports Medicine Clinic. I just want to remind you that these sessions are recorded and you can go back and look at them at a later date if you would like to. Also, you can use the chat function if you'd like to ask a question or unmute yourself in the bottom left. I'm sure Dr. Keating would love to take any questions that you may have while he's presenting. So without further ado, go ahead and take it away.
All right, and thanks for having me. So today we're going to be talking about elbow pain here. My name is Casey Keating from Spine, Sports, and Pain Medicine at Renown. We've had several names for the department. We'll be talking about that in a little bit as well. So my background, I went to Loma Linda University for medical school, did my intern year in internal medicine at Kaiser Los Angeles, radiology at Kaiser Los Angeles, focusing on IR and musculoskeletal radiology. And then I worked as an admitting hospitalist while moonlighting in radiology residency, and also worked in urgent care after that, before deciding that I wanted to do something more clinical and see patients. Went to PM&R residency at Stanford with a focus of interventional spine, sports, and pain. And at that time, my wife said, no more training, you need to work. Also board certified in physical medicine rehabilitation and a diplomat of the American Board of Pain Medicine and the director of interventional pain service at Renown. If you couldn't see me, here's a picture. And so kind of my various experiences let me appreciate many fields in medicine, and I think urgent care is one of the most challenging jobs in medicine, and everything really involved in primary care. Expectations of patients are very high. They expect that in 15 minutes you can do what takes hours in an emergency room with a physician, team of nurses, monitors, stat lab, CT, radiologist, all ready to serve you, and you're just kind of sitting there trying to help the patient in front of you. So 15 minutes to reverse 15 years of pain from the patient is often the expectation. As a hospitalist, having extremely medically complex patients, often a critical setting, and really pain was the last thing on your mind. You're trying to stabilize this patient, but would like to keep painful conditions in mind because that's probably what the patient's going to be complaining about 2 weeks later after they heal from their pneumonia. And radiology, it's truly daunting with the task and the volume required for that specialty. There's an incredible knowledge base, but you don't get to see the patient. And so when we're looking at an x-ray as clinicians, we're really only focused on what the patient came in with and focused on that particular area with a specific differential. So I think looking at your own films can be very helpful. So spine, sports, and pain medicine, also called outpatient physiatry, previously called the pain clinic. I schedule all of my new patients for 45 minutes, do a focused neuromusculoskeletal history, physical exam. I review all of the imaging myself, and we do evaluation and management of anything causing a functional deficit. We do in-house diagnostic procedures, nerve blocks, joint injections, ultrasound, fluoroscopy, and EMGs. So kind of the difficulty with our specialty is the name, and so outpatient physiatry was confusing. We had a lot of people coming in saying, why am I seeing a psychiatrist for my back pain? And then physical medicine and rehabilitation. People come in and think that we're doing physical therapy, and why did my doctor send me to rehab? I don't use drugs has been a thing that people have said. And then the pain clinic, just fill my pills, doc. That's all I want you to do. And so changing the name is really kind of describing what we're doing. And this is similar branding to many of the major programs. So my personal focus is on acute painful conditions. We all deal with chronic pain and acute pain, but anything new onset we want to jump on quickly, and that's been part of the national pain strategy. Spine and sports injuries. And then the fancy title change that is coming up is the director of the interventional pain service. Apparently this will help me in meetings to have a title. So my philosophy is combining the history, physical, and imaging to drive on a specific diagnosis for each patient to have an individualized intervention for their specific pain generator, starting with things that are most conservative that have a reasonable chance to be successful. So a pain generator, what is it? Pain is the fifth vital sign, has been out for many years, but think of pain as something caused this, just like if somebody had a cough, something is causing the cough, so treat the underlying cause. Don't just give everybody codeine if they have pneumonia. And so a pain generator is a distinct structure that's capable of being injured and is innervated by nociceptive pain receptors. So for diagnostic interventional pain medicine, if you think that a certain structure is the pain generator and things are confusing, use image guidance to accurately put a needle there and block that structure or the nerve innervating that structure. There's essentially no false negatives with lidocaine. It works, it'll numb that area. And false positives can be evaluated with multiple blocks. So an example of this is I've looked at thousands of MRI and I've never seen a trapezius strain or tear or a lumbosacral strain or tear. And these are probably some of the most common diagnoses that come in our clinic. If there's a strain, there should be a continuum. So you can have a grade 1 through 4 hamstring tear, but I've never seen that with the trapezius muscle. So on to elbow pain. First thing we want to do is rule out major injuries. So fracture, trauma, medical, infection, skin. Today we're mainly discussing soft tissue injuries. And we should also include adjacent nerves and joints as part of our differential. So cervical radiculopathy is very common. Carpal tunnel syndrome classically would only involve the hand, but often can involve the forearm pain. And rotator cuff can have pain that can creep down the arm as well. If a patient has had a stroke, then consider spasticity. And outside, so also with throwers, we have different things that we would want to be evaluating, but we're not talking about that today. So lateral elbow pain. Lateral epicondylitis, or tennis elbow, was originally described with overuse injuries with a one-hand backhand. Most things that are classically described are no longer true. And so 95% of people that have lateral epicondylitis do not play tennis. And so I stopped using the term tennis elbow because it's confusing to our knowledge workers, which are the majority of these patients. So now it's common with any wrist extension and supination occupation. Most commonly, this will involve the extensor carpi radialis brevis and the common extensor tendon. So here's just a little bit of the anatomy. So there's a lot going on in the elbow, and we'll come back to some of this a little bit later. And so here was just saying what I was saying before, only 5% of people with lateral epicondylitis actually play tennis. This number is likely much higher in Dr. Scott's clinic. So on physical exam, pretty simple physical exam for the lateral elbow. There's tenderness of palpation over the lateral epicondyle, and that's 80% accurate. Resisted wrist extension with a sensitivity of 84% and positive predictive value of 84%. Combining these gives you about 95% if you combine multiple maneuvers. And then resisted third finger extension also is accurate. So do multiple tests and that'll get you up higher. It can also be associated with decreased grip strength, and this can be challenging to evaluate versus a neurological injury because this is a painful lack of strength. And they'll have difficulty with extending their wrist. Diagnostic ultrasound is both sensitive and specific and can be very useful. So on the differential for lateral elbow pain, posterior interosseous nerve syndrome, this is a motor-only nerve, but can result in some of the weakness that we would see with a lateral epicondylitis. This will be a true neurological weakness. Usually there's not wrist weakness because there's still some of the innervation that goes to the wrist extenders. But you'll typically have finger weakness, especially with the third digit. Radial tunnel syndrome will have pain at the lateral elbow. This is also brought on by repetitive tasks, decreased ability to grip. Classically, Tinel sign will be positive at the elbow, but this can also be positive with lateral epicondylitis as well. So the treatment. The nice thing about lateral elbow pain is it really doesn't matter. If you have one of these confounders, the treatment is basically the same. And so stop repeating what's hurting it. You can do NSAIDs. Burst treatments are good. Do high doses of NSAIDs, and always write an end date for these. So what you don't want is to write somebody for ibuprofen 800 milligrams 3 times a day, refills 12, and 5 years later they're still on ibuprofen, and 10 years later they're still on ibuprofen, and now they're on dialysis. And don't start a narcotic for patients with lateral elbow pain for the most part. This is obviously outside of trauma. For physical therapy, this can be very helpful for these patients. I write no dry needling on all of my referrals, and we'll get into that in a little bit. And then rest from the inciting activity. Consider a counterforce brace versus carpal tunnel splint. If a patient has carpal tunnel and lateral epicondylitis, you can give them one brace that'll treat both, because then they're not extending the wrist. The dry needling by physical therapy. When you write evaluate and treat, you're responsible for everything on that referral. There's no amount of time that they will be doing this. Some people will do it once. Some people will do it 3 times a week for months on end and not really give you a report. There's variable training for these. If you go to a weekend course, you're apparently certified and a master of dry needling. And this practice to me makes no clinical sense. So tenotomy has great data, but this is a one-time thing that I would be doing, and then rehab after that. So I've had patients where their arms look like IV drug users because they've been getting needled 3 times a week for several months. Many of them have new calcifications, which can be permanent. It's also illegal in over half of the states. And yeah, this is a weekend course that you can go to be a Master of Dry Needling certified. And I just can't imagine going to a weekend course for medicine and being Master of Medicine certified. So you as the provider take on the liability. That's why they send you a form and have you sign it. And not all of us read everything on the PT prescription. And so when they send it back saying, I'm going to dry needle this patient's eyeball, and you sign it, you're now taking on that liability. So known complications for trigger point injections and dry needling include pneumothorax, nerve damage, vascular damage, worsening of calcifications, and worsening of the symptoms. When you look in the PT literature, none of these things are mentioned because they don't understand the medicine and the complications. So lateral elbow treatment. Here's an ultrasound of the common extensor tendon. And what I want you to look at here is how close this is to the radial collateral ligament, the articular surface of the radial head, and those are outlined pretty clearly on here as well. And so these are less than a centimeter away from our target structure if we were going to do an injection here. The radial nerve is also adjacent. And so these are showing the radial nerve, which are also relatively close to our target structures. Here's a case report on dry needling. This was a patient that I had. He passed out when he was in the PT clinic after a dry needling session. I saw the patient in clinic and he had injections done by the PT. He pointed to the base of his occiput, and I couldn't really believe that. And then I requested the procedure note, and the procedure note was one line. It said, I did some dry needling around C12. And so likely there was a vertebral artery puncture, and luckily no long-term damage, and the patient did not have a stroke. I'm evaluating a case later today where somebody was doing dry needling around the radial nerve, and the patient has a radial nerve palsy. It was a 38-year-old with medial and lateral elbow pain, now had worsening of pain. He had been getting dry needled 3 times a week for 2 months. Also had hand weakness of ulnar innervated muscles. And this procedure note also just said, did some dry needling around the medial and lateral epicondyle 3 times per week. EMG was positive for an ulnar neuropathy with axonal damage. And ultrasound was also positive for a significant amount of scar tissue around the ulnar nerve and lateral epicondyle. So lateral elbow pain. Fortunately, most of these patients are going to get better if we just initiate conservative treatment early. So 80% will have improvement or resolution of their symptoms at 1 year. But that's still 20% that we have with chronic lateral epicondylitis. These are the ones that are going to come into your clinic, and they'll take up a lot of your time too. They're not happy people. So counterforce braces and wrist braces. Looking at some of the data, they improve symptoms, function, and pain at the 6-week mark. Unfortunately, there's no change at the year mark with bracing. Botulinum toxin injections may show some promise, but more research here, and good luck getting this covered. This is a very expensive treatment for something that probably will get better with other interventions. PT and NSAIDs help in the short term, but not great data versus placebo at the 1 year mark. And lateral elbow pain, so blind injections can be injected into the tendon, cause damage, or the radial or posterior interosseous nerve, which are close to our structures, or damage the radial head. The peppering technique, or going in and out and doing a little microtenotomy, can be more effective, but now you're increasing the chance that you can cause damage to surrounding structures as well. So first, do no harm. Doing procedures incorrectly can, little typo there. So doing procedures correctly can improve symptoms in the short term, but doing them incorrectly can cause damage to surrounding structures, and there's really not good data for steroid injections at the 1 year mark. So here was an article in the Journal of Shoulder and Elbow Surgery showing a significant association between steroid injections and calcific tendinosis. So we can permanently make this significantly worse for the patient by doing injections. And the take home from this was 110 elbows, statistically significant, and likely calcific tendinosis is iatrogenic in a lot of these patients. Here was a meta-analysis for injection therapies for lateral epicondylitis. Steroid injections, they're improved at 6 weeks, but the recurrence rate was 32%, which was worse than the placebo if you gave the injection. PRP, stem cells, and autologous blood, they might be helpful. There's really not a consensus for these preparations right now, and these are not covered by insurance. Here was another randomized single-blinded trial of different injections with 112. And for these patients, very similar results. Improved at 3 weeks, but these are actually worse at 6 and 12 weeks versus placebo, and had a recurrence rate of 37%, 34.7% in the steroid group, which was higher than placebo. So if you're going to be doing these procedures, I recommend sports, PM&R, or orthopedics or pain physicians have a significant amount of training. These are actually more challenging than it seems. You might get great results in the beginning, but we could be making our patients worse in the long run. So consider a referral for an ultrasound-guided injection if one needs to be done. Lots of structures that are right around there, and we really just want to focus on the place of the tendon which is most injured. So steroid injections can reduce pain in the short term. I rarely perform these then. So here's a newer procedure. It's ultrasound-guided ultrasonic percutaneous tenotomy. It's a mouthful. Essentially, we're using ultrasound guidance with a larger needle with ultrasound energy at the tip, and we can do some debridement, which is similar to a surgical procedure, and this can all be done percutaneously. So much, much better data for this. So this was a great study that had 3 years of follow-up with 100% of the patients followed up. It's a small study, only 20 patients. And all of these had recalcitrant lateral epicondylitis with pain for greater than a year. After this procedure, 100% of them had improvement of symptoms, and all of them had significant pain relief at the 1 year, 2 year, and 3 year mark. Also on diagnostic imaging, a significant portion, greater than 90%, had dramatic improvements of their diagnostic ultrasound of their common extensor tendon as well. This was in the American Journal of Sports Medicine. So with the diagnostic ultrasound, we can see the part of the tendon which is most diseased. And so here we can see the superficial fibers with hypervascularity and hypoechoic region. So if I'm going to do the 10x on this particular patient, I'm really just focusing on the diseased portion of the tendon. So I'm not going to release the whole tendon, and we can debride some of that and do some of the ultrasound energy right around where the problem is, and it's very obvious with the diagnostic ultrasound. So here is that procedure, and so this is a different patient example. So we're using ultrasound to guide the needle down with the ultrasound energy at the tip, and then on the right side of the screen, the needle is guided down towards the hypoechoic region of the tendon and leaving the superficial fibers intact, because on this particular patient, the superficial fibers were healthy and the deep fibers were the ones where the disease was. So moving on to medial elbow pain. So first, rule out cervical radiculopathy, shoulder pathology, fracture, trauma, and skin. And in throwers, evaluate the medial collateral ligament as well. So medial epicondylitis, also called golfer's elbow. So 90% of these are not sports related. And so again, I still call these medial epicondylitis, just so you don't call golfer's elbow in a person that gets this from mousing. And so lateral epicondylitis is much more common, ratio of about 10 to 1. Most common etiology of this is laborers with repetitive strain injuries as well. 20% of the cases now, much, much higher, are secondary to ulnar neuropathy. So this may look like a medial epicondylitis, but it's actually an ulnar neuropathy. Both can cause grip strength weaknesses, and that can be from ulnar neuropathy or medial epicondylitis. On physical exam. So there's a high correlation with pain at the medial epicondyle combined with pain with resisted wrist flexion. So combining these is important because an ulnar neuropathy can give you pain near the medial epicondyle as well. Diagnostic ultrasound is very effective for differentiating these two, and we'll go into that a little bit as well. For ulnar neuropathy, classically, Tinel sign is positive at the elbow, which will send a shocking sensation down to the 4th and 5th digit in an ulnar distribution. The problem with Tinel sign anywhere is there are a significant number of false positives. And also, one thing to look for is looking for weakness in finger abduction and compare this side to side. So we're taught in med school to look for finger abduction strength by flexing. The problem with that is your finger flexors are way too strong. And so we really can't participate, we can't perceive a difference. And so instead, when you're doing any strength testing, use a similar strength muscle on yourself, on your patient. So an example of this is when I test for finger abduction, I use my same pinky to test that pinky of the patient. And then I try to get roughly the same distance so I'm not giving myself any added lever. And so now I can really feel how strong the patient's finger abduction is. When I'm testing first dorsal interosseous, I do the same thing, pushing with my first dorsal interosseous muscle. When testing a bicep, I'll pull hard because that should be a strong muscle. And so we should approximate the strength of the muscle that we're testing, and we'll get much, much better results from our physical exam. I think you'll find a lot more ulnar neuropathy using this technique than you would otherwise. And I see a significant number of patients with mild ulnar neuropathy that we can treat early and avoid surgery. So diagnostic ultrasound can be very helpful. We can look at all of these structures and see if there's any damage to the tendon or see if the ulnar nerve looks abnormal. Another little pearl on physical exam is see if the patient can split a digit. And so I haven't seen a study on this. I should publish something about that. Yeah. And so if a patient can split the digit, and so on the medial nerve side, if that feels normal, and then it's abnormal on the ulnar nerve side of the ring finger, in my experience, it's basically been 100% an ulnar neuropathy. And vice versa for a median mononeuropathy at the wrist. So if you think somebody has carpal tunnel, oftentimes they'll say the whole hand is numb. The next question I always ask is your pinky numb? And most of them will be like, oh, yeah, no, I guess my pinky's not numb. The symptoms are never there, that's weird. And most of the patients have never thought of that. So if a patient can split a digit, now we're talking about a peripheral nerve injury. With a cervical radiculopathy, it's usually more diffuse where the pain is. And non-traumatic ulnar neuropathy, this is almost always at the elbow. Rarely you can get entrapment at Guyon's canal, but without trauma, very, very rarely is that present. I've noticed that a lot of the surgeons are decompressing the ulnar nerve at Guyon's canal in non-traumatic cases, and most of those do quite poorly. So these patients have a lot of pain. It's a challenging surgery and a lot longer recovery with more pain than a simple carpal tunnel release. And an EMG can be very helpful to differentiate where that is and help isolate where the ulnar nerve problem is. So looking with diagnostic ultrasound here. So we can see ultrasound images of the medial epicondyle for medial epicondylitis. And we have calcific tendinosis in picture B. And on the other ones, we have hypoechoic regions. Hypoechoic is fluid in the area. And so these are signs of medial epicondylitis on diagnostic ultrasound. Ulnar nerve compression. And so here we have a patient with rheumatoid arthritis with a huge synovial cyst pressing on the ulnar nerve. And this is very obvious on a diagnostic ultrasound. So treatment for medial epicondylitis. A counterforce brace can be helpful. However, if a counterforce brace is put on incorrectly, it can compress the ulnar nerve. And if you use a counterforce brace for ulnar neuropathy, it'll likely make things worse. NSAIDs, again, write an end date for those. You can consider a topical NSAID. These are pretty superficial structures. And then again, definitely no dry needling around the medial epicondyle. Injection should be done with ultrasound guidance only, and surgery is pretty rare for medial epicondylitis. For ulnar neuropathy, PT is unlikely to help and may actually worsen symptoms as we're irritating the nerve. A heel bow pad can be helpful. I usually ask patients to wear this all the time for 1 week. This will help to remind them not to put their elbows on firm objects and to avoid excessive elbow flexion, which can compromise the nerve. And a lot of times they'll have pain when sleeping, and they'll wake up because of that. And so having them wear the heel bow pad when sleeping is helpful. Elbow extension splints, there's better data for these, but people hate them and the compliance is very poor. So I usually start with a heel bow, and then if that's not working, then I'll go to an elbow extension splint and have them wear this one when they're sleeping. Peri-ulnar nerve injections may be helpful, but these are typically challenging procedures. Definitely use ultrasound for these, and there are some techniques with 100% accuracy if you're experienced with ultrasound to be able to do a periulnar injection, and patients can get relief here. And so here was a study with 100% accuracy using a certain technique going near the ulnar groove where the ulnar nerve is easy to see. So medications, also think about what's causing this. And so if we have an ulnar neuropathy, gabapentin may be helpful for an ulnar neuropathy or radiculopathy that's neuropathic. And again, the NSAIDs might be helpful as well. So opioids, several articles not recommending opioids for these treatments. Seems obvious in today's day and age. And then benzodiazepines and narcotics should essentially never be used together. There's extensive research on this. I've never seen any article saying this is a safe combination. And just be very cognizant whenever you prescribe any opioid medication. I have this conversation with any patient when I start something. This is an addictive medication. I don't want you on this long term, and I do not allow anybody to be on alcohol or including marijuana. So our license comes from the DEA and the state. If they disagree, I usually just pick whoever is the most strict, and I follow all regulations and really try to. Alcohol is something they're really cracking down on for people not checking for alcohol, or even worse, you look for alcohol, it's positive, and you continue to allow the patient to take opioids, increases the risk of death significantly. And so even just giving a small amount, and so giving a patient 8 days, a 13.5% chance that patient is on narcotics at the end of a year. If you give somebody for over a month, a 30% chance that they're still on at the end of the year. Again, things to avoid: benzodiazepines for use for pain. Avoid oral steroids in most cases. There's really poor data for oral steroids and pain relief outside of autoimmune diseases or inflammatory conditions. But in general, for back pain, elbow pain, don't use oral steroids. There have been several large studies showing no change versus placebo, and also potentially worse outcomes. Just in summary here, so be careful with your physical therapy prescriptions. Physical therapy is fantastic for lateral elbow pain, especially in the short term, but we don't want any dry needling done. We don't want our patients to get worse. Be very careful with injections around this area, and consider the counterforce brace. There is pretty good data for them to be helped in the beginning. And when to refer. So failed conservative treatments. If anybody's in severe pain in the beginning, I think it'd be useful to get a specialist on board as well. And then if there's any question of the diagnosis and to establish a treatment plan, it can be very helpful to get some help on these cases. And if you're on Epic, these are our current tags to get to our clinic, and we'll be changing these up with the rebranding process as well. If you would like for one of us to do an EMG, send a referral to physiatry. So Nevada is a little bit strange with the EMG referral system. We have to say exactly how many nerves that we're planning on doing, which we don't know until we get there. So this makes no sense. And so if I see the patient as a consult first, I request all of the codes, and it's been getting approved. And it's about 14 codes, so it's kind of a confusing process. But if you refer to us and we find something else, then we can treat that. So the chronic disease model of care. So we're trying to move towards this in pain conditions, similar to what cardiology and pulmonology and GI have done. And so basically, even patients that are stable on their current treatment, want to see them once a year and see if there's anything new that we can optimize their care. So a lot of the patients that have been on chronic opioids, some of them have never had imaging done. And it really wasn't clear why they were on them the entire time. They've been on opioids for a decade, and they're stable and happy, but maybe this is a 55-year-old healthy person that just needs a knee replacement. And when they fill in the pain diagram, they bring their own color-coded pencils and fill in the whole body and draw stuff everywhere. And then when you get down to it, it's just knee pain. And so if there's something that we can help and focus on, we can optimize care. And a lot of these patients were able to get off of the narcotics, and many of them back to work. And so our hope is that all of these patients can get evaluated by anybody who's in that field. And so sports medicine, orthopedics, PM&R, pain, somebody to take a look and see if there's anything else that we can do. For acute pain, so the national pain strategy has been to aggressively treat acute pain to prevent chronic pain. And conservative treatments are treatments. So that's part of the aggressive treatment of pain. So somebody that comes in with lateral epicondylitis, starting them on an NSAID, giving them a brace, and sending them to PT, I would consider that excellent treatment in the beginning. We already talked about this. And then, so about that 6-week mark in a lot of the research is when we start to say that this lateral epicondylitis might be something that's going to continue. So if things are not significantly improving by that point, then we would want to start to intervene and really jump on that, because a lot of those will still have pain at the end of a year. Medial elbow pain, so initial treatments, pretty similar to lateral elbow pain, but the big difference here is significantly different treatment for the nerve entrapment versus the medial elbow pain. And it's also a larger portion. So this can be challenging. And thank you for your time.
Dr. Bayou, do you have any questions for Dr. Keating? I'll unmute you so you can ask them.
Okay, I do.
You do?
Sure.
I do. So I think it's worth repeating the steroids and the Medial dose packs should be out probably for most of this, right?
Yeah, so
The ulnar neuritis.
really for ulnar neuritis or for any elbow injection, steroid injections are pretty much out.
And oral too.
And oral steroids, yeah.
Because you see that a lot coming from the ER.
Yeah, ER and urgent care.
Yeah.
When I did urgent care, we were told to basically give everybody a prednisone dose pack if it had any painful condition.
Yeah.
And that's pretty much been out. There's a very large study done by Kaiser, and they have huge mega data that showed worsening of symptoms with giving a steroid pack, and also with the side effects of steroids.
You see that a lot.
So,
What counterforce brace do you like?
really any of them. They can grab an over-the-counter counterforce brace.
Come in with that a lot.
Mm-hmm. And if they have it, just make sure that they have it in a place where they're changing the lever. And so a lot of them will put it right where the pain is on their lateral epicondyle, and obviously it's not going to do anything, so
Right.
move that down. And then on the medial side, just make sure they're not compressing the ulnar nerve.
Yeah, so,
And so
flip that over.
Yeah, you can flip the brace over, use it for medial epicondylitis, and just make sure that it's a little bit distal. The ulnar nerve is going to dive down deep and is protected. But as you get closer to the medial aspect of the elbow, the ulnar nerve gets more superficial, so you can actually get ulnar nerve compression if it's too close to the medial epicondyle.
So I try to tell the patients we're trying to take some of the force off where it's pulling there, where it attaches, so that you want it in here or in here. Not right over the top, but they will come in. They'll get those little things at Shields or Big Five. Come in. It's a lot worse. My arm's numb and tingly now.
Yep.
I'm
very
like, whoops. Let's move that a little bit. So that's an easy thing to fix.
And the topical NSAIDs can be great here as well. So diclofenac gel usually penetrates about a centimeter ballpark, and most of these structures are within a centimeter of the skin, so it's definitely reasonable.
Now, have you ever had any luck or seen any articles about not using those combo, compounded, let's put some, and on a topical, let's put some Elavil and steroid and NSAID, and have you seen those? You know,
Yeah, so
there's actually, used to send you a prescription that said add this and this and this and this.
Compound pharmacies are great if you want a house in Tahoe. You can make a lot of money on them. I don't know how effective they are for your patients, and there's really poor data. It's difficult to study a lot of these things. I haven't seen anything that was compelling for me to order this. Yeah, very, very expensive placebos. Some of these can be $600 to $800 a month for patients, and I personally don't think it's any better than just diclofenac gel, which is covered by insurance.
I had a guy come in wanting me to fill that for him, and I was like, really? How long have you been using this? Yeah, someone's making a lot of money. Do you two have any questions about that? Yeah, will you do the tenotomy on the first visit, or is that typically we have to schedule it for a second?
We usually have to schedule it.
Okay.
So that needs to be approved. Yeah.
It's good when I tell my patient to go in what to expect. You know, this may be something that's done, but it won't be done the very first.
Yeah. And the 10X machine that I showed in the example, so we were supposed to have that a year and a half ago, and it's not here yet. So I'm still working on it and going to meetings and chatting with people. And yeah, it's supposed to be here yesterday, but we'll see.
I've got a question from Dr. Bayun. Can you read that? What sort of referral do you typically get? Failed oral therapy?
So really anybody with any elbow pain for this is reasonable to send over. If they failed conservative treatment, that's always nice, then we can move faster. But if the pain is severe in the beginning, I'm happy to take a look because there might be something else that's going on. So even just lateral epicondylitis, failed conservative treatments is totally fine.
Thanks for the question, Dr. Bayun. Any questions out in Oahe? What's the guy?
And one more thing to bring up is oftentimes these injuries are not isolated. And so you see a lot of the causes for these are repetitive strain. So somebody can have medial and lateral epicondylitis at the same time, and it's relatively common for a lot of our laborers. And also an ulnar neuropathy might be on there and carpal tunnel. And so when these patients come in, they might highlight their whole arm, and this can really look like a cervical radiculopathy. I had a patient relatively recently that's an ultrasonographer, and she didn't tell me even when I was doing the diagnostic ultrasound. It would have been nice to know. I'm explaining things at a very basic level for somebody that probably knows more terminology than I do on this. And so she came in with a referral for a cervical radiculopathy, which was reasonable. She had pain in her neck, pain in her shoulder, pain in her elbow, and numbness in her hand and pain. So when she filled out her diagram, this looked like a cervical radiculopathy. But as we started to go through the examination, her phalanx was positive. She had carpal tunnel compression test positive, Tinel's positive at the wrist, and on diagnostic ultrasound, the carpal tunnel, the median nerve was enlarged at the carpal tunnel and normal everywhere else. So this was carpal tunnel syndrome, which was causing some pain that came up the arm. She also had a significant lateral epicondylitis with calcific tendinosis, and she had subdeltoid bursitis. And all of these were obvious on exam and with diagnostic imaging. But this was a relatively challenging case because it really looked like a cervical radiculopathy with pain in the neck going down the arm and hand numbness. But 3 different injuries, all because of the way that she was sitting and working as an ultrasonographer, and everything was right-handed scanning with her arm way out to the side. And so just changing the way that she was sitting was helping significantly.
Any more questions? Anybody have anything? Topics that you want to hear about in the future? All right, send them in to us if you have anything. Send us cases. And thank you, everybody.
Yep, our next session is August 22nd. So thank you, everyone. Y'all have a good day.